Hello, it's Dr. Janet Pope here, a Room Now reporter at Room Now. Welcome to EULAR 2021. I'd like to talk about when to use a JAK inhibitor in rheumatoid arthritis. And I'm going to go over a few of the abstracts presented at EULAR 2021 this year. So the first study was a single site study of patients receiving an advanced therapy with rheumatoid arthritis since 2014. And 2014 was chosen because that is actually when the first JAK inhibitor was approved in Canada. And full disclosure, this is my single site study, and it was on a poster tour presented by my medical student. So this was poster 0205. And what it was looking at was advanced therapies in rheumatoid arthritis and looking at retention. And the study adjusted for age, sex, RA, disease duration. And what it found overall of over 320 patient cycles of treatment in about 214 patients that, number one, overall retention was better in JAK inhibitors than other advanced therapies, the other bio-DMARDs. And these were usual care access. Now, that was true whether the data were adjusted or not. The second thing that was found was that the retention of a first-line advanced therapy was higher in the patients using a JAK inhibitor first. And again, adjusted and unadjusted results showed the same thing. The separation is often after a year where more retention was found in years 2 and 3 and onward, and the JAK inhibitor users. Now, this is a single site study. I would have my own biases in how I treat patients, and we have better access to biosimilar TNFs and JAK inhibitors in our province. So that might affect results, and it was obviously non-blinded. The second study is, if I use a JAK inhibitor, should I go on to another JAK inhibitor or do something else? So this was looking at JAK inhibitor cycling or JAK to JAK treatment in rheumatoid arthritis. And this is poster 0223. These are data from over 40,000 RA patients from the OPAL registry, which is a large database from the EMRs of patients in Australia. And these RA patients, about 4,000 or so, were using JAK inhibitors. And what it found, not surprisingly, was that 1 in 4 of the patients on an advanced therapy were starting a JAK inhibitor, but more recently, in the last year or two, over 40% of the patients were starting a JAK inhibitor as first-line advanced therapy. Here's where I'm kind of surprised. They found that using a JAK inhibitor now as a JAK to JAK therapy strategy is about 40% of JAK usage. So JAK the first one, then the second one. I think we're going to have to look over time on what this does to retention, going JAK to JAK versus JAK to other line of therapy. Now, the final study to briefly talk about is there a predictor of which JAK to use in an RA drug failure population? So this was poster 0221. And what it was looking at was JAK treatment resistance. And it looked at patients on either baricitinib or tofacitinib, single site study, 150 or so on each of those groups. And they were trying to look at predictors of treatment resistance. So not surprisingly, if you had a higher HAQ score and had been exposed to 4 or more biologic DMARDs, you are more apt to have a bad treatment response on your JAK inhibitor. So that's no surprise. That would be true, I think, in any treatment algorithm, that the more you failed and the higher your disability, the less likely you'll do well in rheumatoid arthritis with the next treatment. The unusual thing in this study was that they found that this was true in patients using tofacitinib, but not baricitinib. The numbers were about equal, so I'm not sure why it wasn't found in both groups. And I think more research needs to be done. So, can I use a JAK in RA? Of course I can. What line of therapy should I use it in? Well, it's approved in all advanced lines of therapy. That'll be up to you to make your choice. And will I have predictors of who will respond? And should I go JAK to JAK? I think those two questions need further answering. Thank you and enjoy us at Room Now.